Welcome to Berries in the Interim podcast, where we explore the cutting edge of innovative clinical trial design for the pharmaceutical and medical industries, and so much more. Let's dive in.
Oh, welcome everybody. Welcome to In the Interim, the podcast of Berry Consultants, and we look at as much as we can into the science, clinical trial science. We look at clinical trial results. We talk about statistics related to medical decision-making, related to clinical trial results, clinical trial design. That's our focus. And so today I'm going to talk about something that turns out to be incredibly controversial. So the name of this podcast is Politics, Religion, and Ordinal Outcomes. Funny name, of course. My reference of this is that you should not at the dinner table, you should not talk about politics and religion. Turns out you probably shouldn't talk about ordinal outcomes as well. Everybody has different reactions to them. Everybody analyzes them differently, a passionate feeling about them. It's kind of interesting because it's ingrained in the history of clinical trials. I'm going to essentially describe that almost every endpoint is ordinal, so you can't escape this. So what are the controversies? How they show up? What do I think about ordinal endpoints? You may not think that this is a controversial topic. It turns out to be really controversial. So ordinal endpoints have been around since the start of clinical trials. I'm not a historian, but my scouring of Google and the internet, that really the first clinical trial was 1747, and it's attributed to James Lind. He was a Scottish naval surgeon. He was very, very interested, of course, in 1747 in scurvy, the scurvy. And he ran what is attributed as the first clinical trial. Now, it's not the first randomized clinical trial, and I couldn't actually figure out exactly how he assigned patients, and that's an interesting part of the trial. So if you want to read more about this, by the way, it's really wonderful reading. You'll find yourself in a black hole reading about James Lind, reading about scurvy, and reading about this particular clinical trial. You can go to jameslindlibrary.org and read all about this. So in 1753, he published a treatise of the scurvy. So I'm reading parts of this. I found it absolutely fascinating. And of course, in 1747, he writes that armies have been supposed to have lost more of their men by sickness than by sword. And so he makes reference to that more of the English army died from scurvy than the French and Spanish armies themselves killed. And so huge problem of the time. And he was interested in whether this calamity could be prevented and the danger of this destructive evil obviated. There were, interestingly at the time, there were tons of theories as to what could prevent scurvy, what it was, what was causing it. We have a pretty good idea at this time, but he was very interested in this. On May 20th, 1747, he conducted the first clinical trial. He took, as he describes it, 12 patients in the scurvy on board the Salisbury at sea. Their cases were as similar as could have them. They all had putrid gums, the spots, and lassitude. I don't know what that means. With weakness of their knees. So he, of course, recognized that we want these patients to look the same. He had strange inclusion-exclusion criteria, obviously not written down, but he did everything he could to get 12 patients that looked the same. He describes a common diet. He describes what it is: a water gruel sweetened by sugar in the morning, fresh mutton broth for dinner, And of course, he refers to supper as different than dinner. Barley with raisins, rice, and currants, and with wine. So he did really smart things for the first clinical trial, trying to get patients to look the same, tried to treat them the same in things except for the interventions he was interested in. So he had 12 patients and he had 6 different treatments. He gave 2 of them quart of cider a day. He gave 2 of them 25 guts of elixir vitriol 3 times a day. He gave 2 of them spoonfuls of vinegar 3 times a day. 2 of them, and he describes it interestingly, 2 of the worst patients, their tendons in the ham rigid, seawater, a half a pint a day. He gave 2 of them 2 oranges and 1 lemon per day. And 2 of them, bigness of nutmeg 3 times a day. This was a surgeon recommended therapy. Again, lots of people were describing what they would do for the treatment of scurvy. By the way, that I don't know what that is, but apparently it had garlic, mustard seed, radish, balsam of Peru, gummer, and cream of tartar. And the interesting thing in all this is he does not describe how they were assigned. They were randomized. He assigned them. An interesting part of a clinical trial that we now think a really important part of the trial. And that's really left out of the description, which is a fascinating aspect of this 1747 trial. I'm much more interested in today's discussion of ordinal endpoints, of how he classified the outcomes of this trial. So he writes, and I'm quoting from his writing, the consequence was, the results, the most sudden and visible good effects were perceived from the use of the oranges and lemons. 1 patient taken being at the end of 6 days fit for duty. The spots were not indeed quite off his body, nor his gums sound. The other was the best recovered of any of his condition, and being deemed well was appointed nurse of the rest of the sick. So I don't think this happens in current clinical trials, that a patient did so well that they become a caregiver of the other patients in the clinical trial in that scenario. But the description of this is the 2 best patients out of the 12 were those that were on a single treatment, the oranges and lemon in this scenario. So his outcome was an ordinal outcome, actually resembles what we might call a DOR patient, that or almost a win ratio type thing, that comparing patients to patients, these patients did the best. There's no quantitative aspect that this patient was 5 times better than that patient or double that patient. There wasn't a mean time to recovery in all of this. It was an ordinal outcome. By the way, if you calculate a p-value for the probability that lemons and oranges would have the 2 best patients, it's 1 out of 66 or 0.015. You, of course, would say, well, wait a minute, there's multiplicities here. There were 6 different treatments. What's the probability that any one of them would have had the 2 best? Well, that's 1 out of 11 in that, which is 0.091. So adjusting for multiplicities, you get 0.091. I'm more interested in the endpoint. Now, interestingly, in part of this, and this may resonate with people, that this didn't change anything. We now know this was actually the right treatment, that it's about vitamin C, and lemons and oranges would have prevented the scurvy and would have had a massive impact. It took 47 years beyond this before this became recognized as the way to treat patients. Interestingly, the thought was that you give dehydrated fruit because it was hard to keep fresh fruit on board ships and all that. And it turns out that loses much of the vitamin C content, and it's not clear that would have had any actually benefit. So CMC issues and PK/PD issues could have really helped James Lind in 1747. So that was the first clinical trial. And I again, you should go read all about this. It's absolutely fascinating. The first randomized human clinical trial is attributed to Austin Bradford Hill. And he published a paper in 1948 of the first randomized clinical trial, which was experimenting on streptomycin for the treatment of pulmonary tuberculosis. And this was published in the British Medical Journal in 1948. This trial enrolled 107 patients, and the difference between James Lind's trial and this one was that the patients were randomized to the treatment. And they were randomized to the control group, or they were randomized to streptomycin in it. The publication of this is also very interesting. There's a traditional table 1. Maybe he invented the table 1 and the table 2. But table 1 gave demographics of the trial, and table 2 gave the results. So what was the endpoint of this first randomized clinical trial of humans? There were randomized, people probably understand there were randomized agricultural experiments, but there were not randomized human experiments before this. The primary endpoint of this was what you think of now as a more traditional ordinal endpoint. It was a 6-level ordinal endpoint. The top level was considerable improvement. The next was moderate or slight improvement. Then no material change, moderate or slight deterioration, considerable deterioration, and death. 6 outcomes. By the way, they aren't given numbers. They aren't given, you could consider giving them letters, A, B, C, D, E, F. F is the worst, A is the best. So all this is it's ordinal in that one is better than the other one, but no numeric number is given as how much better. We think of these as ordinal outcomes, and it's probably what you know as ordinal outcomes. So controversially, how did he analyze this? We would fight today, I mean fight in a good way, that we would fight about how to analyze this endpoint. What do? He analyzed it actually in multiple ways. He talked about in this outcome, the first thing he did was he talked about deaths, and deaths were 7.3% in streptomycin, and it was 27% in control. And he talked about this being less than 1 in 100 chance that this would happen. He then said the best split, if you split it in any particular way, the best split for streptomycin for this was considerable improvement, which was 51% to 8%. 1 in a million, he talks about the likelihood that that would happen by chance. So he's giving p-values, he's analyzing it. We would recognize, the multiplicity of looking at the best place and what does that mean? And that gets everybody in a bother. Now, this was an easy analysis where any way you analyze this endpoint, it looked really, really good. And so there's not going to be a whole lot of struggle on this endpoint in there. And I went back and took the data and I fit a proportional odds model to this. And you get a proportional odds of 5.43 to the good of streptomycin. The lower bound of the 95% confidence interval is 2.64. This is a massive effect. P-value of that is 6.3 times 10 to the minus 6. Awesome data. Makes it really easy. Everybody can, look at this and say, this is clinically really, really important in it. That was some 75 years ago. We still fight about how to analyze ordinal endpoints within this. Okay, so we're still fighting about this. I'm going to focus to talk more about where are we today, what are we doing in ordinal endpoints, what do I think about ordinal endpoints from this. I'm going to pick a particular example, very similar to Austin Bradford Hill's endpoint of 6-level ordinal endpoint. We're going to talk about the modified Rankin score. The modified Rankin score is a 7-level ordinal outcome. It's used on the neurological status of patients. It's quite common in a number of scenarios. It's quite common in stroke trials where the endpoint is your modified Rankin status at 90 days, 180 days, different points. The endpoint itself is 7 levels. They do give numeric values to these. The numeric values that now we'll talk about, are they relevant or not? Are they just labels? And they're labels. You could have labeled them A, B, C, D, E, F, G. But I'll give the labels that are there. You may be familiar with them. 0 is no symptoms, perfect neurological status. 1 is no significant disability. You're able to carry out usual activities. 0 is better than 1. We can argue about how much better. We're going to get to that. 2 is slight disability. You can look after your own affairs, but unable to carry out all previous activities. So you have some disability. 1 is better than 2. 0 is better than 1. 1's better than 2. Then 3 is moderate disability. You need help. You require help. 4, moderate to severe disability, unable to attend to your own bodily needs without assistance. Again, a higher level of support needed to carry out daily activities. 5 is severe disability, bedridden and requiring constant nursing care. It's commonly given the label of vegetative state, clearly a worse state than 4, worse than 0 through 3, and then 6 is dead, no neurological status. So these are the 7 outcomes. It's a very, very common outcome in clinical trials. The question is, how do we analyze this thing? How do we analyze those 7 outcomes in a clinical trial? There's huge disagreement that goes on about analyzing this. There's disagreement about the medical interpretation of these. There's disagreement about statistically how to analyze them, the relative meaning of the values of them, and different analyses are used. The first way to potentially analyze these, and I shudder to say it, but is to dichotomize these. Very common in clinical trials, the modified Rankin is dichotomized. There's even a name to the dichotomization, and it's disabled or not. So 0 through 2 is considered a responder, a good outcome. 3 through 6 is considered a bad outcome. And the clinical trial analyzes how many of those are 0 to 2 and how many of those are 3 to 6. That's a way to numerically analyze these outcomes. Now, I'm going to walk through this a little bit, and I want to start by saying this is mathematically equivalent to giving a weight of 0, 1, and 2 a value of 1, giving 3 through 6 a value of 0. I could say that's my utility and analyze that way, and I get mathematically the exact same answer. Okay, so it is a weighting by doing that dichotomous, and you're saying having a 0 is equivalent to having a 2. Having a 3 is equivalent to dead. Absolutely. That is the assumption that's being made when you analyze the trial that way. I shudder at that. I shudder at that clinically. I shudder at it statistically for a couple reasons. The power of a trial that lumps everybody together, 0 to 2, 3 versus 6, is lower than a different way to analyze it. I think it's clinically harder to interpret. I don't think any person has a utility function that is equal to that, but it's very commonly done. Okay, another way to analyze this endpoint, you could probably understand what I think about 0 to 2 or any dichotomization of that endpoint. What about a proportional odds model? So a proportional odds model is a statistical assumption that the effect of moving patients to a higher level has a statistical odds of that happening. We assume it's the same of moving people from 6 to better than 6, from 5 and 6 to better than 5 and 6, from 4, 5, and 6 to better than 4, 5, and 6. The odds of that is constant across the scale. There's a strong, I don't want to say strong, I'm sure I shouldn't say that word. There's a statistical assumption that comes with that odds is the same across the scale. Now that gets statisticians all ruffled. It's almost like when you go to graduate school, you have to question that assumption in any model or you're not worth your statistical salt within this. It is an assumption. Now, and it can be violated. The interesting thing about it is that a way to analyze that ordinal endpoint imposes a utility on each of those outcomes. Remember, dichotomizing them imposes a utility. And you can mathematically write it down. A proportional odds model imposes a utility on it, and you can mathematically write it down. What is the utility? The interesting thing is the utility of that is based on the prevalence of the outcomes. If you have a lot of zeros and ones and 10% deaths, but 90% zeros and ones, your utility you're imposing is highly weighting 0 to 1 differences because that's where your prevalence is. Death and above that is down-weighted because they aren't very prevalent. You can mathematically write it down. I could give you the utility functions as you're imposing that upon your endpoint. People don't think about it that way. It's a little bit uncomfortable. If alternatively you have a lot of 4, 5s, and 6s and very few zeros and ones, but you have some, you're downweighting those because they're not prevalent. You are imposing a mathematical weight of those outcomes by analyzing that way. You can't get out of that. Okay. I'm not saying that's bad. I've used it. By the way, I've used both of those in clinical trials. I struggle with the dichotomization, but I've done it. I've done proportional odds model, and I don't necessarily shudder at them. But I understand I'm imposing this strange sort of weight on them. Okay. There are other ways to analyze these endpoints. We could do a Wilcoxon test. We could do a Cox model on them. First of all, I want to point out that there are tons of ordinal outcomes. This is the one a lot of people are familiar with. Mortality is a ordinal outcome. Yes, no, mortality. It's ordinal. Now, that's a pretty simple dichotomous one. It's binary. Time to death, overall survival in a cancer clinical trial or any clinical trial is an ordinal outcome. A year is better than 6 months, but you don't say how much. You just say it's better. When you run a Cox proportional hazards model or a log rank test, you're analyzing an ordinal outcome on that. When you're analyzing infarct volume or tumor size, sometimes people say that's quantitative. Well, no, it's ordinal. You're imposing upon it the difference between them of 1 unit being a numerical difference. You're imposing upon a quantitative weight of that ordinal scale, but it's ordinal. Almost everything is ordinal. The best corrected visual acuity, where you're looking at a chart and saying, how many letters can I see? It's ordinal. We calculate a mean of them. we make the assumption that one letter is better no matter where you are on the scale, that it has a constant difference. We're imposing a quantitative weight on them. People are comfortable with that. When I impose a numerical value to the modified Rankin, people jump up in arms. People, scientists, regulators. So there have been several studies that look at patient preference for the modified Rankin, that look at the economic value of them, and they're actually very similar. We have taken them and said, okay, we're not going to do a proportional odds model. We're not going to do dichotomous. Nobody has that weight. We're going to use this, and we're going to call it a utility function. By the way, the weight that is used on that is a full weight of 1 if you're a 0, 0.91 if you're a 1, 0.76, 0.65, 0.33, and then 0 for both 5 and 6, that those are equally bad. That's a utility function. You can analyze it, very simple statistical models, no assumption of proportional odds, and we can analyze it that way. Now, people get frustrated by that. Lots of people, in terms of regulators, what does this mean? And the first criticism is, not everybody has that utility weight. You're using 2 different studies, but how do we know the people that you're analyzing that have that weight? The problem is, any way you analyze this endpoint has that same issue. If you dichotomize them, you're imposing that everybody in your study has that weight of 111, 0000. My claim is nobody has that weight, but yet it's very commonly done, but nobody's frustrated by that. Bothers me because I don't think anybody has that weight. Studies, phase 3 clinical trials at FDA use proportional odds model. There's a comfort in that. You got to check assumptions. You got to look at proportional odds, the usual thing we do for Cox models and all that. You're imposing a weight. How do we know the people in your study have that weight? My point is, it's a false criticism because you cannot escape it. You have to weight the endpoints any way you analyze them. All of these endpoints, we impose a weight on them when we go into a clinical trial. But when we specify it up front and try to justify that this is a good weighting system, everybody throws arrows at it and, oh, that's bad. But dichotomous and proportional odds, that's a good way to do it. All right, so what do I think of this? I think it's the really hard thing in a clinical trial. It's the way, as we move forward, we're going to get more and more fine-grained understanding of endpoints. Our endpoints are going to be more strength, more valuable. We have to do this. It's hard. Science is hard. Medicine is hard. Hiding behind ad hoc ways to do this, I think, just leads us to bad places. It disconnects the statistics from the clinical outcomes, from the doctors, from the clinicians. This is where we need to go. We need baby steps. We need to work there. We need to show it's valuable, that it's good for regulators, that it's good for patients, it's good for statisticians. But it's really the only way to do this. So I think as our endpoints become more signal, less noise, wearables, daily values, our iPhone, our iWatches, our things, calculating things for us, these are all ordinal outcomes. That this is the only way forward. We need to go there. Let's do baby steps. Let's analyze the modified Rankin in really, really better ways, smarter ways, explicit ways in this. And please, let's not just dichotomize really nice endpoints. Again, I don't think anybody has that weight system. All right. Well, I hope I didn't defend you like I would if we talked about religion or politics. It's a controversial thing, but I think it's a really important thing in clinical trials. I hope you enjoyed the discussion. And till the next time, we are in the interim.